I was born in Uganda, raised in Uganda, was educated in Uganda, and a few courses outside of Uganda, but I've had my practice as a medical officer in Uganda, especially in Virika Hospital, where I spent a good number of years as an undergraduate and also postgraduate. I've done a few things in administration when I was heading the hospital. And then right now, I'm the current president of the Gynecologists of Uganda. And I also teach in St. Francis Hospital, have a postgraduate program. And right now I'm in the field operating women with fistula and birth injuries. Just a nutshell of who I am.
Great. I've got some questions for both of you, but our hope is that this could be a conversation and many of the people here joining will add their own questions. Dr. Priscilla, what do you think is the greatest joy in your practice right now? What keeps you sort of optimistic and hopeful?
I think the most important thing is that when I help a woman, especially now that I became specialized, I just feel very fulfilled to see that I have put a smile on someone's face, even if I don't do much, but listening only and finding that someone lives with a different face, a different feeling, that makes me feel very good. And when I started the practice of gynecology, especially when I saw the misery of many women in the rural areas and how sometimes they cannot access specialized doctors, and you repair them and they whisper that they are dry, they are no longer sleeping in urine, I would feel like every time I hear that, I feel like, okay, good enough. Yeah. Thank you.
I'm sure you have many of your former patients in the community who see you and recognize you. Is that right?
I do, and I have many who have children named Priscilla. Yes. Yeah.
Nice.
Yeah.
As someone who takes care of people more at the end of life, almost all the patients that I've taken care of are no longer alive. So we are jealous of those of you who have patients who are out there and grateful and recognize you. So maternal infections during labor and delivery, during the delivery of a baby, used to be one of the leading causes of death in women and one of the leading causes of death in communities. Is that a problem that you see? Is it a potential greater problem as these bacteria become resistant to more antibiotics?
Yes, it is still a problem, and commonly here, especially women who are in reproductive age, and they come with obstructed labor or difficult labor for who are not medical personnel. Difficult labor where a woman spends 3 days in labor and she's having these contractions strong, and maybe she's in the village, the traditional birth attendants are examining her without even right things. And then they arrive in facility with very, already infection has set in. Even when they get, for example, the surgery or medical care, they have an infection. Even like today, the same story where we had a very challenging patient who was in the hospital today, and she developed a fistula, 3 days in labor, arrived when the bladder was already injured. So they are busy treating with antibiotics, and we even can't repair her right now. So it's still a big problem in the community. And another thing is that they become resistant because they seek for help, and a neighbor in the community gives you treatment, like, you first swallow this medicine. And so they arrive when they have taken lots of other antibiotics, and then at the end of it, they become resistant.
How big of a problem is it? What's the mortality of delivering a baby right now in Uganda and at your medical center?
In Uganda, we still have the same thing of 16 women dying every day in childbirth and pregnancy and its complications. So the last 5 years, our demographic health survey is always 5 years, we still stand at 336 maternal deaths, which is still way high up. So, and right now, even in our hospitals, at least every month you have a maternal mortality audit. And that is a very good hospital, but in the government, in public hospitals, it's even worse. Yeah.
And that's in a country about roughly, what would it be, 1/6 the size of the United States, to give us some context. It's about what, 40 million, 45 million people in Uganda, something like that.
Right.
Are those deaths primarily infections?
Not really infections, primarily, I think top on the list is hemorrhage, where women get postpartum hemorrhage or after delivery, they bleed a lot. And then that one is the commonest because of the delays that happen. Definitely when a woman delays, the uterus does not contract normally the way it should if they intervene in time. So when they arrive late, then they deliver and then they bleed, and sometimes the supplies are not there. Sometimes the human resource, once the baby is out, the woman is already exhausted and she lies in bed quiet, and I think she's okay only when you are very observant and come around, you find she's in shock, and then before you turn around, she's dead. So hemorrhage is top on the list. And then we have obstructed labor, difficult labor, and then sepsis. And then now we are seeing a number of women also especially in the city, with hypertension or preeclampsia, and the abortions are also quite a lot in our facilities.
What would you say is the most high impact intervention that reduces avoidable harm, either avoidable morbidity or death?
I think the greatest thing, we need to change attitude of healthcare workers. We've got to come back to our senses and know that this can be me, this can be my mother or my sister, and then treat people with the difference. And then that helps us to care more, to take observation, and to mentor each other. And also the supplies in public facilities, supplies is a challenge, but also in the community. Poverty is still a big problem, that women delay coming because they can't afford, they don't have transport, or they even delay to make those decisions to come. So we need the human resource with right minds, right intentions, and probably that's what I think. And functionalize our centers, the medical centers, I think important.
Maybe I'll dig in a little deeper, or somebody else will, on pressing you on what your greatest need is. But let me go in the interim here to Jonathan. Jonathan, what I've observed in my minimal time looking at hospitals in poor settings in Africa and overseas is that sometimes we tend to think they need medical providers. But what I often see is that sometimes there are bigger gaps in nursing care, in the management of nursing, in medication availability, in the supply chain, in turnover, in equipment cleaning. And these are issues that I think sometimes get overlooked when we think about delivering, physicians to areas of need.
Yeah, you're absolutely right. In terms of when you think about what we've observed, even from AMH with working with our partners, is that the clinical care keeps improving, but the administrative functions, the management around the system don't increase in the similar way that the clinical aspects are improving. And so there are other auxiliary services and support that is required to actually come around and ensure that there's a system that is functional, that the providers, when you have good clinicians, professionals, you're able to work in that space in a way that is actually efficient and effective. So you're increasing productivity. And Marty, if you can allow me to just go back to something that Dr. Priscilla was talking about so that she can help us understand. She's one of the kindest human beings I know, but just like John, if you mess up with your patients, that is where now things become very interesting. So I would like her to even just talk a bit about one of the things which she's really helped us and pushed us to implement, which is the rule of 6, to ensure that we are taking care of these mothers in a way that actually is supposed to be the case, which is something she's really pushed as hard, and all of the network of the hospitals we work with in the Southwest region to focus on when she does our clinical audits. Dr. Priscilla, if that's okay,
Yes.
the 666 rule, you've
Sure.
taught us.
Yes.
Until now we can speak about it.
Yes, the rule of 6 also stemmed from my very, very good mentors, that it's a way you can follow up a woman. And when, for example, she has delivered, she has had a normal delivery, actually the first hour is very, very important. But in order to make a mnemonic for people to have it right, we call it a rule of 6, meaning after 6 hours, whether delivery or cesarean section, the mother must be evaluated very well, know her vitals, her blood pressure, her pulse, her everything. Is the uterus contracted? Is she bleeding or not? Her concerns, basically. If it is a C-section, that's the time, and it was spinal, you need to start maybe feeding as early as that. And also to know that if the baby has been breastfed, it's important that that is the time she needs to put the baby on the breast. So after evaluating after 6 hours, you need after 6 days, for example, she's been discharged, to follow up in the community, because if there is potential infection, you really would catch it up around even that time, it will be obvious. And then 6 weeks, we need to know again if she has gone back to the pre-pregnant state, so that you examine her if everything has settled and all signs of pregnancy and the effects are gone, whether the baby has been immunized. And then after that, we can allow her even to advise her on spacing, and also to maybe start her really sexual function. And that is the time also we can do cervical cancer screening. So we call it a rule of 6 with those summarized key things. Of course, our laboratory investigations are part of it on after 6 weeks review.
Yeah, and the reason I was referencing that, because she's taught us a lot on that space, is there are various aspects and implements that we need at every stage of the 6. So ensuring that the things that the provider needs to be able to do a good exam are there, the supplies that are supposed to be there, the nursing care that is supposed to be there to follow up on those aspects. On the day 6, which is when for the our program we follow up even on ask questions on patient satisfaction and ask about patient experience, then follow up and also do a cervical site infection protocol, because we realize there's no difference between doing a home visit and actually the call itself. And then week 6, which is where Dr. Priscilla is leading us to now, is to be able to introduce cervical cancer screening using very low cost aspects. But Marty, you're absolutely right. The importance of just having a system that is working together, trying to solve this with very strategic investments that allow the providers to be providing care.
It's really amazing how nursing care is critical. Yeah, it really is. And protocols and standards and a culture. Great. I've talked a lot. I'm sure people have a lot of questions here to ask you, both Jonathan and Dr. Priscilla. I'll open it up. If somebody would like to ask a question, please feel free. And if you prefer to throw a note in the chat, I can always ask it. Let me ask you a little bit more, Priscilla, also in the interim here. What do you think is the future right now of obstetric care in your area, given the new people who come through the ranks, the students who are finishing, the people who are interested in practicing, those who get lured away to other areas? Tell us a little bit about the workforce and the outlook for the future.
I think I must say the future, I think is exciting if we have the right people mentoring the right students. For example, I must say like St. Francis Hospital, the postgraduate training, I'm like so happy that they gave me a resident that I was able to come with to the field. And so you see how he sees how you handle people, how you handle tissues, how you introduce yourself to the clients, and how you follow them up. I think they feel like they can't read it in the books. So I think we need to build a team and have doctors who can mentor the young people, so that it's not about money, it's not about, but it's a call to revamp that feeling that medical profession and being given the opportunity to care for women or other patients is a special call. But also I think it has been seen by the Ministry of Health now. There is a whole program that they want to do mentorship in the whole country. And we've been talking about it, that once people are mentored, they are coached. Even those who are specialists, we need to do refresher courses. Learning never ends. There are also a lot of things that I've learned from here in the field. So I think it's the way to go, to mentor groups and follow them up and find out. But many times medical profession, you finish and no one ever talks to you, finds how you are doing, whether things are going into the right direction. So I think if we did that, mentorship would be great. And I'm glad that part of our program is to do mentorships and teach the young people what to do. Yeah.
Thank you.
Maybe you can share a bit, Marty, before we go to the question, just because you rallied all of us around a dream in the Southwest region, which involves the mentorship and the training, which is with you and your congregation, the Daughters of St. Teresa's, Mother Teresa Sisters. Maybe you can just give us a few highlights on some of the key things and for your dream there.
I'm so sorry, the phone had gone off because I'm using the phone and the internet on the phone. Sorry, can I have your question back?
So yeah, I was just asking if you can, before everybody asks the question, because I know you rallied all of us around the dream for the Southwest region and the plans that you have for that area. Maybe you can just share a few highlights on some of the things that you see happening in the next few years in that area based on this new initiative.
I'm really excited about the Mother Teresa Health Initiative, and I'm very grateful to be named as the winner of the prize, because definitely I'm the face of so many people that we work together as a team. But I really look forward to see that we build this center and it becomes a model in this region, that people can come and see where people are given respectful care, where students can learn something that they cannot learn with the busy professors and busy wards, but they can have time to learn and know how to treat women or children. And also to, have standards, because sometimes many facilities have lost standards. I know there are SOPs and people follow them, but sometimes it's hard to see a particular center which is like a center of excellence in a particular region, especially in the rural. These places where women can access the center in a walking distance. And to find that someone is there available for you all the time, and to have the right skill, the right things you need to be investigated, and also to see that we provide a service not in the city but in the rural with equivalent standards of those who are in the center, in the cities. So I really look forward to that. Already there are very good things that are happening. Like now, since the surgical camps have started, I'm really grateful for the award and the support that at least this is the first time we are out to do this, like for example, in this Rushoroza. And since the program is involving the Southwestern region, so the hospital where we are is part of this initiative. So we are really excited about it. So far, like we are training the doctors in this facility, and next time we think when we have another camp in the Rwaivale Health Center, they will come to polish up what they have learned, and maybe the third time in another hospital, and then we are comfortable that they can do very good service without our presence. Yeah.
Congratulations again, Priscilla, on the award. I want to go quickly to Perry and then to Doug. Perry, I think, had a question for you.
Yeah, thanks, Priscilla. Thank you so much for what you're doing. You're such an inspiration to all of us. I think at AMH, we're really delighted, I think, to come alongside African healthcare leaders and really be able to highlight the work that you guys are doing. And also, I think to help to highlight, I think, local solutions rather than just adopting, WHO or other kind of external principles, to highlight local solutions that have come up. And I was just wondering about, I think about it in terms of the rule of sixes, as well as other things around birth injury and things that you're doing. How we could maybe best support doing sort of amplifying and using what you're doing, the lessons you're learning, to be able to spread those really throughout the region, that some local solutions could be backed up with some data and evidence on the impact so that they could be adopted regionally and impact more people. I guess the question is, do you have any data on the impact of your work, and how best could we support coming alongside you to amplify your voice really for the whole region?
Okay, so right now we developed a questionnaire to use in our birth injury camps, and also just to let you know that we use this broad term birth injury because when we use fistula, it brings a little bit of stigma. But when you use birth, everyone feels good. Birth is something nice, giving life. But in an event that you are giving life and you get this injury, we need to take care of it. So we get people with all the series of trauma through birth and then fistula with part of it. So we have the questionnaire now that we are trying to administer to these patients. And also what I have seen the impact is that the patients I have operated are the messengers in the community sometimes who call me and bring other women. So with time, we can build a number of women ambassadors. They are the ones who will mobilize their fellows in the community because they know each other, and then they come. And then also we've involved the church several times on occasions and announcements in the church and so on. That's how we've been able to get to these women. But we are definitely, I'm very open. I'm not very good researcher, but I'm working with researchers. That's why I will need help to say, like, we put our ideas together so that we can have, be more helpful to the communities. Yeah. Have I answered you?
Yeah, definitely.
Dr. Priscilla is not a researcher, she says, but she's supervises us who are students trying to do some research. And part of answer to your quick question, Perry, I can see, I think Joe Collars is here. We're working closely with others, like Joe Collars at Center for Global Health, Equity in University of Michigan and others to try and really shape up and map out how to measure impact. Because as you know, as we've discussed several times, it's a much deeper issue, and we want to be able to highlight the good work that Priscilla and her team are doing in a way that everyone else can see, and we can replicate, and we can share it in the appropriate forum.
Like, for example, in this camp, we received 107 women. The first day it was overwhelming to find all these women waiting. And like, really, from this community? And just on announcement that there's gonna be help for women who have sustained birth injuries. So we started the assessment, and we assessed all of them, but we were able to pick 34 women with birth injuries. So yesterday we operated 10, today we've operated 12. So we need to finish now on our list. Now today more were coming in. But it's amazing to see how people live with a problem, 5 years, 10 years, and they're just seated on it and like as if no one cares. And yet they are mothers of children. They have really given life and they have lost their own life, their own dignity, I would usually call it. So it's something great.
I want to go to Doug. Doug had a question.
Thanks. Thanks, Dr. Priscilla. This is fantastic. So I'm wondering, are you involved with training local birth attendants at all, and interacting with folks who are working out in the village and whatnot? And also, if you are involved, what sort of interchange you have with them, both in terms of them communicating with you with referrals, and then also providing feedback back to them, both for care provided and how to do follow-up care for the patients that you've taken care of. Okay.
So in Uganda, at first, and some years ago, we had a program of gathering the traditional birth attendants in the community. But at a certain time, ministry also removed it when maternal death was increasing. So then we got a program of Saving Mothers Giving Life, where we said, let's encourage the traditional birth attendants to give them a motivation every time they bring a woman to the labor. And then that way it increased our skilled birth attendants. So the old women, whenever they would get a pregnant mother, they would bring her to the facility for delivery. So that worked a little bit well, but some projects that are not sustainable. So when the project closed, it also closed on them. But the COVID time, I think, has done a lot of, again, traditional birth attendants, because people were locked up, there were no means of transport. So the women in the community were again delivering them. So as a country, we've not encouraged again traditional birth attendants, although we know that they're doing that. So here, for antenatal purposes, what we do, we talk to women and tell them, look here, the traditional birth attendants are there, but you need to deliver, you need in a sterile environment, because you can get complications and you can get maybe a tear. You need a facility where they will stitch you. So it's beginning to take action slowly that people come, but I know there are still those who deliver with the traditional birth attendants. But also another reason was the lack of respectful care in facilities. That women come in the facilities, they shout on them, sometimes we are rough on them. So they tend to prefer those other old women who understand them. So I think if everything changes, that we get to know that really we need to change our attitude, the skilled birth attendant will increase. And then also when the traditional birth attendants are doing something, we can reach out to them and talk to them, advise them to maybe accompany these women. Yeah.
Thank you, Priscilla. John? Great. John Fielder wants to ask you a question.
Okay.
Well, hi, Priscilla.
Yes, John.
I wanted to just follow up on this, the issue of the efficacy of the interventions. And I think we should set the stage for just how difficult things are. Priscilla mentioned the maternal mortality rate in Uganda, and it hasn't really improved in the last 5 years. Some African countries have seen a significant improvement, but Uganda not so much. A study from 2 years ago found that in Africa, the risk of a woman dying after a C-section was 50 times that in the West. A woman faces a lifetime risk of death in Africa from maternal complications, so meaning across the number of pregnancies she's had, of about 1 in 40. And of course, in some countries, it's higher than that. Now, with Priscilla's clinic in a place called Ribale, and she's right now in a place called Rusha Rosa, and there's a couple of other of our partners, we have a C-section sponsorship program, and that's to encourage women who may not have the resources to not delay, so that they know that they could get to the hospital and receive that care. And I looked at the first over 800 C-sections that we've sponsored, and the maternal mortality rate in that cohort was about 120 per 1,000. And as Priscilla said, it's more like 330. I've even seen 380 per 1,000 in Uganda. So it's about a third in our program. It's about a third the national rate. However, our program is C-sections, and the national rate includes uncomplicated deliveries, standard vaginal deliveries, etc. So I think what it shows is that with systems in place and mentorship by people like Priscilla, and we try to come alongside to provide equipment, to provide training, to build the operating theater and the pediatric ward. So you're wrapping around everything from the infrastructure to the training to making sure that the patient can afford the care. And when you do that, you can see significant improvements.
And John, if I can add just one more piece, that was the excellent insight. I mean, if you look at the trend, the data from 2005 to 2015 went from 671 to 343. Now it's 336. And like you said, a lot of people ask in that study, why did this happen? It wasn't because they expanded the health system significantly, it's just that they added the infrastructure, those other pieces around the system to be able to support that, as you've highlighted, that ensures the entire system is improving. And right now what they say is that every year you anticipate a reduction of that number by 3 points. So from 343 to 340 year on year. So for you really to reach the 200, which is what the WHO says as a start, it takes you, I mean, you can do the math. It'll take us a few years to get there. So we're in this for a long, long time to keep improving the system and things that Dr. Priscilla and you have identified.
Hey, Marty, if I could real quick, and hello, Priscilla, how are you? It's great to see you. This is Scott. Good to see you. And Jonathan, one thing that might be worth describing, John alluded to it, and Priscilla talked a little bit about her vision, but maybe Jonathan, if you could start and Priscilla could complement, maybe explain the bigger picture of investment that's being made right now in Ribale as a rural center, because we mentioned the Center of Excellence. We talked about Priscilla winning the L'Chaim Prize, but this isn't just a kind of a scattered instead of activities. There's a lot of thought going into developing something that'll have a lasting impact there. So maybe if you could just describe it for people, it'd give a sense of the kind of improvement we're trying to help make in partnership with Priscilla and the Banya Teresa sisters.
So I think that, thanks Scott for that. The context here, we've had a long-standing relationship with Priscilla. I think we first met in 2012 when she was serving in a different hospital, and we've subsequently started partnering with Priscilla and Sister Gertrude, who you saw. She's somewhere there.
Yeah, she's around here.
And the Banya Teresa sisters, who just an amazing team to work with. And over time, we started with investments that are focused and around what we now see is surgical capacity. In the first hospital, it was an X-ray machine. It was a generator, because in Uganda, sometimes power goes out for 6-7 hours. And after that investment, you could see the C-section volume significantly increased while the quality remained the same. It's housing, staff housing, which people will overlook. But for us, we know for you to have staff who are dedicated, you need to have housing where they can stay, because in the rural markets, there's no rental market really. So over time, we've made investments, and our approach is usually to go and sit and listen to Dr. Priscilla and others and the sisters and say, what other things do we need? So as an example, one of the key needs also presented, as you heard, is healthcare workers. And we worked with the sisters under Sister Gertrude's leadership to train over 53 of the nuns as healthcare workers, and some of them as doctors, and not just from Banya Teresa's, but also other networks. And you look at procuring right now, even for Rushorosa, where they are working to help them procure an anesthesia machine because they've had an unreliable one for a long time. Build up trainees in surgeons, trained surgeons who can go back again and teach and perform these surgeries there. And then in Rwevale, when we started having the conversation, the maternity was not even finished, completed. But over time, there's housing has come in, together with Collaborating for Better Health and Chokolas, the surgical unit is in place. We're looking at a pediatric building we just got completed last week, and then others like the center, which Priscilla has been dreaming about, putting it together there, and training. So it's the training itself of the healthcare workers, the infrastructure for the healthcare workers to work in, and programs that engage the community. We have a very good program, Universal Health Program, which provides primary care for over 8,500 people around Rwevale, which we also used to engage and work together with the leadership of the sisters to ensure that we engage in the community. So given our relationship over time, we are able to have this conversation where we listen, identify the needed investment, make it, and then track it over time and plan together while bringing in others on board to make sure that is happening. The C-section program is a good example for us, because it's the way us at AMH we think about long-term impact is through the eyes of the patient, the eyes of the hospital, and the eyes of the broader health system. So it's the network. And the C-section program, as you can see, it helps the mothers. It helps stabilize the hospitals, because a lot of these mothers who come for emergency C-sections can't pay, so won't pay. And the hospital is stuck with that cost. And then the system, because now we have a network of 3 hospitals and a 4th one that is waiting for resources, that when Dr. Priscilla goes to do the clinical audit and mentorship, they're always asking her, can you stay here for longer? And then she tells us, you know what, this hospital needs a new surgical bed. The lights are not functioning properly. Then we sit together and then make that determination to do that investment. So over time, it's something that we've working very closely with the sisters on the ground to be able to develop, and the broader network, because we also have a very, very good partnership with the Uganda Catholic Medical Bureau.
Great. I have a question, but Scott, did you get your question completed?
I did. Thank you. Thanks, Marty. Go ahead.
Okay. Anyone else have a burning question? We've been talking about oxygen and the amazing excess of oxygen capacity we have and take for granted in the United States, and how oxygen is really in very limited supply and can sometimes just support a few people with basics. Have you run into issues of insufficient oxygen, and how's the oxygen capacity for maternal care?
Yes, this has happened a lot. Even you've seen, it was embarrassing that even the consultant obstetrician collapsed on the ward and there was no oxygen and they had to die. before they arrived in ICU. So it's a big thing that happens. It's a problem. And like in the rural, you've got to carry these cylinders and go to all the way like to Kampala to fill them, like 4 hours on the road to fill the cylinder to bring it to save babies who need oxygen. So people, I think, also oxygen concentrators, people are using them, but power is not stable. So every time you don't have power, then the oxygen concentrator can't help. So I think people are beginning to think of having like oxygen plant so that they can have oxygen most of their time. Yeah. So, but it is a challenge and it's a problem.
What operation were you doing today, Priscilla? Can you tell us about the case?
Yes, I did 6 operations today. I started with the woman who had what we call it a 4th degree tear. She delivered in the community, and she's been like that for the last 6 years. And I told her, why did she come this particular time? And she was like, because I had the announcement and there were people that they will support us for treatment. And so she came, and I asked her how many times she's been like to like market or church. She said from that time she ceased going anywhere because of the smell that surrounded her, because she was incontinent of her stool, and also even a little bit of, she can't control urine very well. So that was the first one. We had to put her together and make her a human being again. And then also we had assessed 2 women with fistula, and one of them was very difficult, but I plan to do abdominal repair tomorrow when it's very fresh. It was close to the meeting. I'm like, no, I need to attend this meeting. So we scheduled her for tomorrow. So, and then also cystocele, blood prolapsing, and these old women couldn't, urinate very well until you have to touch yourself to push back this bladder. So those were the operations we did today.
Are you only involved in complicated deliveries or problems, Priscilla? For routine deliveries, do you send those to other people to handle?
So right now, the cesarean sections, I usually don't participate in them, but I'm more in urogynecology and treating those women with problems of urine and leaking and prolapse. But because of having residents in the hospital, when there's a cesarean section, I love to stand there and see how they do it, or put in a glove and say, no, here, do this way, it's a better method. So I love to work alongside residents. So yeah, but most of the time it's the complicated surgeries that I do, the myomectomies, the hysterectomies. Yeah.
Amazing.
And Marty, that is just typical. That is a typical Dr. Priscilla response. I think in the Southwest region, if I'm not wrong, there's only 4 urogynecologists for a population of almost 10 million, I think.
Wow.
Yes, we are few. And for example, we have a fistula technical working group in the country, where we are 23 for the whole country, and most of them are going to South Sudan to repair women, to Ethiopia and so on. But to scatter ourselves, all crowded around the city, but of course, fistula issues and uro issues, for many doctors, they're not paying operations. But for us who know how fulfilled you become when you dry a woman or make her feel better and attend a social gathering, you feel that this is the best kind of thing you can do for a human being. So yes, we are few, but I think we are trying to make sure the young ones can join us.
Great. Thank you. We're reaching the end of our time here. Scott, any other thoughts?
Well, Marty, thank you. I just want to just step in and say thanks to you for hosting, Marty, and Priscilla. I know how hard it is to communicate from Uganda. I'm so glad our Wi-Fi held up and that you were able to make time today. And it's a blessing always. It's wonderful to see you and Gertrude and all the people that work so hard in Uganda. Hello, Gertrude. I also want to thank the Medical Advisory Board for joining the call and for Jonathan being one of the speakers. I hope you hear, the sincerity and the passion that people like Priscilla have to provide care in the areas that they work in. And I know you appreciate this, but we can tend to take a lot for granted here in the West that they don't necessarily have access to. And just having your support, you listening to them and hearing what they're up against and what they're doing, I think is very encouraging. And so we appreciate your time today very, very much. We have recorded this session and we will push it out to all of you and all the MAB members. And if you would like to share it with anyone else that you think would like to hear some of this discussion, please feel free to do that. We just want to spread the word so people do understand what's happening, and it's not all bad. It's very encouraging. Priscilla's dream is a beautiful dream, and we're just so excited to be part of helping her do that. And so with that, John or Mark, if you had any final comments, I welcome them, but I really want to thank everyone for joining us today.
Oh, thank you, everyone.
Thank you.
All right. Thanks, Scott. Thanks Mark,
Marty.
for putting it together. Good to see you again, John Fielder. Thank you, Priscilla and Jonathan.
Thank
really
you.
inspired by you. Keep up the great work.
Thank you
Hope to
very
meet you
much. Thank you. Thank you. It was a pleasure meeting you. And Sister Gertrude is saying thank you.
Thank you everyone on behalf of Anya Teresa Sisters. We thank you for all you do for us, and we are happy for this meeting. And also we are lucky to have Priscilla as a member of the Anya Teresa Sisters and for all the work that she does. Thank you so much for all the support you give us. God bless you.
God bless you. Thank you.
Thank you. Thank you. Thank you. Goodbye.
Goodbye. Thanks, Priscilla. Bye-bye.
Thank you. Bye.